Hi, good afternoon to everyone, or good morning wherever you are, as Steve told. My name is Jafer Zorkun. I'm a clinical cardiologist. I work in Istanbul University, Istanbul Medical Faculty. Also, I work in Istanbul University Institute of Oncology in a clinical oncology department as a consultant cardiologist. Today, I'm gonna show you one of my cases from my past in previous university from Edirne. Also, I still follow this patient. The title is Treating a Lung Cancer Patient with Pembrolizumab-related Myocarditis and Pneumonitis after PCI. But actually, the title should be Management of Myocarditis, Pneumonitis, and Nephritis in Non-Small Cell Lung Cancer Patient during pembrolizumab treatment a month after PCI. I first seen this patient in January 2018 in Edirne. 65 years old male, presented with chest pain, palpitation, shortness of breath, and fatigue. He was on chemotherapy for lung cancer, adenocancer. At first, doxorubicin was initiated for his treatment. 5 months later, disease progression was noted. PD-L1 tested, and then pembrolizumab was started. I've got this information from oncology history case. The day before I saw him, he received the 3rd dose of pembrolizumab treatment. 2 milligrams per kilogram, his dose was. In his medical background, diabetes mellitus without any treatment, benign prostate hypertrophy, lung tuberculosis. He said he got a treatment, but he was not sure about that. And this person was live in Edirne, but he got 2 citizenship, Bulgarian and Turkish. The part of his life he lives in Bulgaria, just next to Edirne. He got recent diagnosis of non-small cell lung cancer, a 47 by 30 millimeter mass located at his right lung, and he got vertebral metastasis. He was an ex-smoker, stopped upon his lung cancer diagnosis. He was smoking 40 cigarettes per day for 25 years. He said he didn't use alcohol. His initial laboratory values show that just normal thrombocyte level, a bit higher creatinine levels, high LDL, a bit higher glucose level, and higher anti-proBNP levels. Just before his cardiac testing. Then his ECG, he got sinus rhythm with incomplete right bundle block with some repolarization abnormalities. At that time, unfortunately, images are not available. In January 2018, he got mild left ventricular depression. Ejection fraction was 45% with inferior wall hypokinesia. Slight mitral regurgitation, slight tricuspid regurgitation, and his systolic pulmonary artery pressure was 37 millimeter mercury. This is his chest X-ray at first admission, in January 2018. Just for comparison, I've got it from archive. This was from 2017. Just I'm showing it for comparison. Also, right lung mass shown here. His thorax CD at initial diagnosis, just a month before cardio-oncology visit. Also, this is PET-CT for staging at time of diagnosis. Right pulmonary mass is visible. After that, oncologists started doxorubicin. After 5 months, they realized disease progression from another PET CT. Then they did PD-L1 test and they switched to pembrolizumab. At that time, pembrolizumab, I mean Keytruda, was not available in Turkey. And if oncologists order such a drug, we will be able to just order it from outside of Turkey. This is just general information about pembrolizumab. I think any of you don't need such an information. Yeah, then we did coronary angiogram to this patient because he got chest pain. Also, oncologists asked us that she wanted to continue with pembrolizumab and they need for patient's coronary situation. This patient got right coronary artery stenosis, tight stenosis in third segment. Then we put two, myself, I put two drug-eluting coronary stents to his right coronary artery. And this is his ECG just day after percutaneous coronary intervention. After 2 days of hospitalization, we discharged him to home with this medication: atorvastatin, sacubitril valsartan, clopidogrel, carvedilol, aspirin.
Afer, I think we lost your audio. So we may have to just wait a minute and see if Kafer can get his audio working again. Might be an internet connection issue. Kafer, you may have to rejoin.
I'm sorry, I think I've lost the connection.
There we go. Yeah,
okay.
You're back now.
Okay, sorry for this trouble. Let me to repeat it. Our hospital records shown that his pembrolizumab treatment restarted 2 weeks after discharge from cardiology department. Shortly after the fourth infusion of pembrolizumab, the sixth in total, he had sudden onset fever, palpitation, fatigue, dry cough, dyspnea, nose bleeding, and sharp chest pain. Then he applied to emergency department in the same institution. At emergency department, marked hypoxia was noted. ECG revealed incomplete right bundle branch block and sinus tachycardia. Right pleural effusion was found in his chest X-ray. Systolic pulmonary artery pressure was 55 mm mercury at ICOS. Diagnosis of pulmonary embolus was eliminated. At the emergency department, empirically administered piperacillin, tazobactam, and fluconazole combination, but it was not effective. Following day, he then transferred to an intensive care unit for disease progression, consulted with a cardiologist, with me, and then a high-dose methylprednisolone and mycophenolate mofetil were initiated for grade 4 pneumonitis. This is the same thing again. At that time, laboratory values at intensive care unit was white blood cell 9400, platelets 347, creatinine was a bit better than before. First troponin level is 11.5, The second one is 34.9. NT-proBNP level was 13,900. And CRP is higher, 61.2, and procalcitonin level was 9.7. Then, just before my consultation in intensive care unit, people in intensive care unit switched to carbapenem, 2 grams per day, ciprofloxacin plus fluconazole, also no remission. This was the chest X-ray at the time of emergency department admission. And this is the second one just before I saw the patient, just before they asked me for consultation. At that time, diagnosis was grade 4 pneumonitis. Then we were talking about side effects of pembrolizumab. At the end, we both agreed, and they agreed that this is not an infectious pneumonitis. It should be a pembrolizumab side effect according to clinical situation. Also, an oncologist involved to our medical discussion. Then we decide to switch drug, and we decide to diagnose at side effects of pembrolizumab treatment. According to National Cancer Institute common terminology criteria for adverse event, grade 4 pneumonitis is life-threatening respiratory compromise, urgent intervention indicated, for example, tracheostomy or intubation. They've just intubated this patient. On the 5th day in intensive care unit, cardiac MRI showed uneven local thickening of left ventricular inferior and posterior walls and patched myocardial signal intensity, increase in T2 weighted fat suppression images. In anterior and inferior walls of left ventricle and in ventricular septum, patchy lesion and delayed contrast enhanced T1 imaging was observed, which was supported diagnosis of myocardial inflammation. At the beginning, 1200 milligram per day methylprednisolone and mycophenolate mofetil 1 gram per day I have started. Immediately after that, from the second day, the patient was better than before. In intensive care unit, left ventricular ejection fraction was 35% with anterior, inferior, and septal valve hypokinesia. Systolic pulmonary artery pressure was 40 to 43 millimeter mercury. No pericardial effusion was noted at that time. In intensive care unit, except pembrolizumab, all his medication written by the cardiologist continued in entire hospitalization. Also, low-dose furosemide was initiated and continued. Just 2 days after initiation of methylprednisolone and mycophenolate, patient has slight clinical improvement. And in another consultation, also another doctor from intensive care unit, they again started antimicrobial treatment to this patient. Even they say, okay, we want to prevent patient from any other things. Methylprednisolone dose reduced to 30 milligram per day. Discharged to home on June 28, almost in 3 months. He hospitalized. Also, he was in intensive care unit. Mycophenolate mofetil 1 gram per day continued after discharge. After 2 months, he became symptom-free and discharged to home with mycophenolate mofetil. And those are some references. I mean, what we learned from this case, this is also one of the border stones in cardio-oncology in that institutions. First of all, we need to improve our medications record with exact dose and timing. Then ECG records. People, they record ECGs, but those are disappeared immediately. Also, this is the same thing for echo images. PET scan images, they are still available, but somehow they just block to reach. I mean, those images are not reachable for every other physicians in same institution. Also, cardiac MR images. It's a usual thing in my country. If any person, if they do any clinical trials or any clinical study, they think that they have a right to cover all patients' results and images. Any other physician, unfortunately, is not able or are not able to reach those images or results. Those things to be improved in a current situation. This is another thing. I mean, the patient is still alive. Even I moved from Edirne to Istanbul from a year and a half, but I've just got this image from patient himself. Also, I've got his permission to show his case as a monthly case in this meeting. In left kidney, he got this problem. Also, his oncologist was not aware of this situation. Also, his current checks, I'm so sorry, this is a chest x-ray from January 2020. Previous one, that one was from
Schaefer, I think we lost your audio again. Just hold tight, everyone. I think it'll come back. I think there's a internet interruption. So let's just hold on. Dr. Zorkun is in Turkey. I think maybe the internet connection is not great right now. Sorry about that.
I think I've lost the connection again.
Yeah, yes, okay. You're back now.
Just a simple collaboration may solve this problem. I'm just, it's open for any criticism or discussion. Thank you for listening to me.
Any questions or comments? Feel free to unmute your microphone and jump in. Anyone want to ask a question or make a comment? Go ahead, Ahmed. Ahmed Iqbal, you had your hand up?
Yeah, can you hear me?
Yes.
Sure, I can hear you.
Yeah. I want to ask about an oncology question. This first patient was diagnosed as adenocarcinoma of the lung. I don't know the reason why they started doxorubicin as a first line.
Honestly, I have no idea about why oncologists started doxorubicin, because even I was not able to ask anything to them why you started such a thing to this patient?
Yeah, because the other question, because that's also oncology, because I'm a clinical oncologist, then because it came to my mind, because as it is adenocarcinoma, no record about this EGFR mutation studies.
Definitely.
Yeah, that's, I think there is some lacking in the this oncology part, but I feel.
As a cardiologist, I think I have no right to criticize any oncology.
Yeah, sure. Okay, thanks.
You're welcome.
Okay.
I wonder if we have any oncologists on the call who want to comment on that course of treatment. No? Go ahead, Amit.
Hi.
Yeah. Yes. Hello.
I think somebody is.
Amit, go ahead.
Yeah. Because regarding this oncological management about this patient, ideally after this adenocarcinoma, that's a histological diagnosis. In any part of the country in the world, now they will do the EGFR mutation studies like exon 19, 20, 21. If it is there's a 790M mutation is positive, then they will start the drug called osimertinib. That is second line. First line, they will give the chemotherapy, non-anthracycline based chemotherapy, they can give, if it is only chemo, they can give carboplatin, paclitaxel, so one combination, or they can give other whatever the available combination depend on the availability of that particular country. I think this as a first line doxorubicin, because maybe the unavailability of the drugs maybe in that country, there's a maybe that reason. Otherwise, because after that the PDL1 they have gone for after that maybe I don't know.
Actually, I was not sure about the time of diagnosis and when they started Dr. Robinson to this patient, because during my presentation, I was trying to indicate that he lives in 2 countries.
Yeah.
The center, the oncology center in Edirne is a really good one. It's like, I mean, according to my country's conditions, they really well developed place. Even they are still able to check PDL level, positive or negative. Also, they have good possibilities for their patients. They are leading currently 26 or 27 clinical trials at that time. But I was not sure who started doxorubicin to this patient as a first-line therapy of lung cancer. Even I was not attempt to criticize or ask them why they are starting to such a thing, because as a cardiologist, when you try to cooperate to an oncologist, even you cannot think about that without forget about asking. When you criticize their treatment, they stop to cooperate.
Yes, sure.
But day after day, I mean, I'm involving to any oncologic treatment. Even I do share your feelings according to this case. But I mean, as a cardiologist, to see such a situation, we are just careless. I mean, my responsibility is treating that patient, not criticizing oncologist.
Yeah, yes, sure.
But thanks a lot for your comments.
Okay, welcome.
Okay, I see another question. Maybe Amit.
Yes.
Ombun.
Yes. Hi. Hello, everyone. Thanks for the great presentation. So a few questions, actually. So do you know by any chance, as in, I think you might not, what was the cumulative dose of doxorubicin that the patient had received? And was the initial consideration that when his EF had dropped, was it because of toxicity or doxorubicin toxicity, or was it primarily coronary or ischemic cardiomyopathy? I know there was an inferior wall motion abnormality, but what was the thought process behind that? And follow up on the same, as in, could we have gotten an MRI and determined whether there was anything, or like, did he have any functional testing before having the heart catheterization? And third question would be kind of thinking about his checkpoint inhibitor myocarditis. Did he have a baseline troponin, as in clearly he had the workup before, as in he had the coronary stent and stuff. Did he have a baseline troponin that went up, as in it would be hard to determine whether it was just myocarditis causing the troponin elevation? Certainly we saw the features on the MRI, but um, uh, kind of that was my, those are my questions.
Okay, thanks a lot. First of all, I remember in a note, but it was not an official note. Patient got something 250 milligram in his doxorubicin doses. I remember such a thing. It was not the official document. Just for that, I didn't take it to my presentation. In second question, I didn't do any functional test before cardiac catheterization because patient came to us with a chest pain. The third one is we got MRI, but I was not able to reach. It's in institutional archive. I was not able to reach, even with patient's permission. I was not able to take them from hospital's archive because oncologists in general, not just for this case, because I have good relations with.
Dr. Zorkun, I think we're lost your audio for a minute again. Have to wait a second here. Sorry, folks, for the interruptions, but I think it's just a bad connection.
Technology is great when it works, but when it doesn't.
Exactly. Well, while we're waiting, are there any other questions or comments? I think he can hear us. Maybe you could.
عندكش مذاكرة؟ تعالى اغسل المواعين.
Can you hear me?
Yes, you're back.
Yeah. Did you hear my all explanations, or shall I repeat them?
I think you need to repeat them, yeah.
Okay. At the beginning, I didn't do any functional test before cardiac catheterization because he came with a chest pain. The second thing, he got MRI images, but as a cardiologist or any physicians outside of oncology, we were not able to reach all those images or take them from archive. Even if patient permits us to do that, oncologists just block all those images. When they do any trial, they said they have a right and they don't share those images. The third thing is, yes, at that time, during diagnosis of myocarditis, patient got 2 troponin levels. One of them at the beginning, 11.5. The second one is 34.9. If I come to your third question, I was not sure about those right coronary problem, even if it is from doxorubicin treatment or pembrolizumab treatment. I'm not sure about that. I'm still not sure about that because there was no any additional data. There was no any initial evaluation, initial cardiology evaluation prior to doxorubicin or prior to pembrolizumab treatment. I hope I could give enough explanations to your questions.
Sure, sure. Just one follow-up. Do you guys follow these patients on doxorubicin routinely with echoes?
I think in that center, just our department at that time was able to perform echocardiography. I haven't seen any echocardiographic evaluations in patients' available files. Even just entire file, in his entire file, just 2 ECGs I was able to get. I mean, this is just a real world.
Certainly, great. No, thanks for your comments and thanks for answers.
It is much more better now. We have a system now. We have a, after that, I mean, as I said, this is a cornerstone in my cardio-oncology life. Now in my institution, every patient got online ECG. Every physician can see this ECG. If they have enough permission, they've got ECGs, they've got echo images, they've got MRIs, and so on, even exact medications. But 2.5 years ago, we were not able to provide those images and those systems. Same machines, same instruments, same people, but just we changed the situation. Just for that, this is a really important case for us. Also, he lives in 2 countries. With this case, we were just in touch in Bulgarian people, Bulgarian administrative officers, and just even if he needs something during pandemic times, he is able to cross the border and come to the hospital. Just for that, I mean, in this case, we got a lot of things and we educated ourselves. Can you hear me?
Yes, yes. Any other questions or comments? All right. Well, Dr. Zorkun, thank you so much for your presentation and for the time. Sorry about the technical challenges along the way, but
I'm so sorry for that. I'm so sorry for that. Whatever I did, I couldn't solve the connection problems. I don't know how to improve it.
Yeah, no worries. Not a problem. That's one of the challenges and joys of doing this internationally. We get to learn from each other, but there's some challenges along the way. No worries. Well, thank you everyone for joining the webinar today, and we have another one this evening if you'd like to join, and then of course next week there'll be another presentation on COVID and cardio-oncology. So thank you for joining.
Thanks a lot. Thank you.